moving on now to our next speaker, who is Christine Welburn, who is based in Wrexham Miller Hospital and Betsy Cadwallader University Health Board. Is that right, Christine? It is Wrexham, isn't it?
Glenclwyd.
Glenclwyd. Oh,
yeah, Lisa's Wrexham.
Yeah, it's in the same.
We're the same, we're Holborn, yeah.
So Christine is in the position as a thromboprophylaxis nurse. That is her role. And she is working with colleagues up in Betsy Cadwallader to make changes across the health board to improve the uptake of thromboprophylaxis risk assessment and reduce the HAT rate. Christine is a very active member on the All Wales steering group, and we can always rely on her if we're sending out information to the group for comments, that Christine will engage along with the other members. And
is that Andrea frozen? Oh no, she's back.
Thrombosis policy. So maybe Christine, she's younger than us, Marilyn. You know, maybe we should be preening her for the future. Anyway, so I'm going to hand over to Christine now, who Christine in 2018 took Wrexham Mailer and Glenclwyd hospitals into exemplar status. And now Christine is going to talk about that for the next 25 minutes or so. So thank you very much. Over to you, Christine.
Thanks, Andrea. So I'm just going to quickly talk to you briefly about our experience of how we achieved a VTE exemplar status and how that's shaped our practice. So like Andrea said, I'm Christine, I'm the thromboprophylaxis nurse. I'm based in Glenclwyd Hospital, which is central North Wales. And then I have colleagues, Lisa in Wrexham in the east and Rhiannon in the west as well. So, there we go. So the National VTE Exemplar Centre network was established back in 2007 by the Department of Health with the aim of reducing avoidable death, disability and mobility from hospital associated with VTE.
Christine, sorry to interrupt you. Could you open up your screen to slideshow, please? Just to make it larger, if you wouldn't mind.
Try. I've been having IT issues all week.
Oh, okay. Maybe you need to.
If you go to this bottom toolbar at the very bottom of your page, so you get accessibility, and then you go along to notes, and then there's 3 little square things, and then something that looks like a goblet on the right. That's it.
Oh yeah, I found it. There we go. Oh god. Oh, there you go. Can you see that better now? Yeah.
Thank you.
Fab. There you go. The VTE Exemplar Leads are Professor Aria and Emma G, and they say that VTE Exemplar Centres form a diverse and enlightened network of hospitals that have existing track record of excellence in VTE prevention and care, and offer practical support and advice to other centres by sharing their resources and collaborative on clinical research into VTE prevention. Now, all the information is on their VTE England website, if anybody's interested in researching more information on what exemplars are. But to achieve VTE Exemplar Centre status, it acts as a kite mark for VTE prevention care, and exemplar status conveys quality to not only patients but commissioners as well. And it access to a community of healthcare professionals who are interested and rigorously involve themselves in quality and innovation in VTE and prevention. And it also allows you to be networking and sharing of resources and ideas with each other. And also importantly, it's recognition for all the staff of the excellence in VTE prevention, because without the clinical staff, we wouldn't achieve this. So I think they need to be appreciated for the work they've done as well. So any healthcare organisations in England and Wales can apply for VTE exemplar status, providing they've got the evidence that they meet the criteria. Now, if you think you've got the criteria and you've got all the evidence, you can go onto VTE England's website and apply on the application form, and the VTE leads will be in contact with you and you can share your evidence, and they'll create an interview and come and see you on site. So I'm not going to go into details about this, but this is just the categories that they ask you for evidence for. So first, they ask you for your VTE strategy that needs to be endorsed by your chief executive. Section 2 is about your compliance and processes. This is the biggest section. It's the most data heavy. You have to prove all your data for all the audits and your compliance to the targets. Section 3 is your training and education. Section 4 is your communications. And section 5 is your implementation. And lastly, section 6 is your patient and community. And then once the VTE leads review all your evidence and done an interview with you, then they will assess whether you gain exemplar status. So if you do get exemplar status awarded, you have to renew that every 3 years. And so we're coming up to our first revalidation in a few months' time and towards the end of the year. So our revalidation criteria is about our risk assessments, thromboprophylaxis, our root cause analysis, patient information, and importantly, displaying the qualities of an exemplar site status, and also our education and staff, meaning we've got somebody in post that is leading on the VTE prevention. So I just want to quickly talk about the experience that we've had in our Welsh hospital. It's been a little bit of a roller coaster ride up to getting up to our exemplar status, and also during the last couple of years, which has been a bit roller coaster because of the pandemic and what we're now doing to prepare for revalidation. So hopefully by the end of this, you'll have a little general idea of how actually achieving the exemplar status has helped shape practice at BCU. So back when I got appointed in August of 2017, I became the first full-time thromboprophylaxis post in our health board, shortly followed then by Lisa in Wrexham and then in our other site in Bangor. And back in 2017, our hospital had several issues. We had high rate of potentially preventable HATs, hospital-acquired thrombosis, and we had low compliance with completing the VTE risk assessment in the Clarkin Performer, although, like Andrew said, in Wales we do it on the drug card and we have our own VTE box there, but we also have it in the Clarkin Performer in BCU, and that wasn't being done. And we also had a lack of VTE education to staff and patients, and importantly we had a lack of lessons learned feedback. So when I started, there was a lot of senior clinicians saying we don't have a problem with VTE, and that was basically because there was nobody really doing the root cause analysis and not feeding back to all the senior clinicians. So that changed the mind once I was in post, and that started getting fed back. So because of these issues, in September of 2017, we started our thromboprophylaxis walk around as our first quality improvement project. And that consisted of myself and my clinical lead for thromboprophylaxis. And we got a very good lead pharmacist who comes and does it, again, on his own free time. And this gives us the opportunity to go around the wards, randomly assess patients' records, so we could assess whether the VTE risk assessment was completed, whether the prescription was correct, and if it wasn't, we could get that corrected to provide more safety for the patients, and give education to the staff and patients, and give them real-time feedback to the clinicians, which was really helpful for them to understand the importance of VTE prevention. We set up education programs so all staff can get VTE education, and that led us to doing a lot more quality improvement projects and audits with lots of staff from different departments. and we created an MDT working approach to VTE prevention. And then importantly, once we got the other thromboprophylaxis nurses in place, we created a BCU approach. And then the other important factor that I want to quickly mention is how we work with the All Wales Thromboprophylaxis steering group, and how that's created All Wales working, which has really helped us. So this is our walk-around team. So in Glenclwyd, there's myself on the right with our clinical lead, Mr. Hannah, who is orthopaedic consultant surgeon, and Heyman, who is our lead pharmacist for surgery as well. And then on the left, we've got Lisa and her clinical lead, Dr. Watson, who is consultant hematologist, and they have a pharmacist as well. And I think the reason why our walk around works so well is we have a lead for each of the disciplines that we're asking to change practice and asking to be involved in the project, and we're all saying the same message. So I think the messages are really important in the quality improvement project. So all these improvements led to a dramatic reduction in our potentially preventable HATs in 2018. I think our last potentially preventable HAT was in June of 2018. And then 2019, we had 0 potentially preventable HATs. So that was like 18 months with no potentially preventable HATs. We was really proud of what we managed to achieve with all the clinicians. And so all these improvements led to us gaining our exemplar site status. We became the 33rd exemplar site. So to touch on our All Wales working, since getting the exemplar site, we think it's really helped, especially because when I first started, we're very lucky in Wales that we've got this All Wales Thromboprophylaxis HAT steering group, which is chaired by Professor Simon Noble and co-chaired and supported by Andrea Croft and Marilyn Rees. And this is such an amazing group that, I feel really lucky that we have in Wales, because when I first started, I was very novice, and to have these people leading the group who are very experienced and very knowledgeable really helped me. And, you can just email them, you don't have to wait for the next meeting and get advice. And that really helped me to create these changes and get people more excited and enthused about VTE prevention. So although the group has slightly changed in the direction, as Andrea and Marin's said, over the last year or two, I think it's an amazing group to still have. It's a very supporting group, and because there's 2 health boards now in this group that have exemplar status. We've got Cumtaff, who was the first to get exemplar status, and then followed by Betsy Cadwella. We can really help to support all the other health boards in the group, and we have a really good mixture of clinicians attending the group. So we have doctors, nurses, pharmacists, quality improvement managers, and because it's one or 2 people from every health board, it really helps. Like Andrea said, she's done a real good presentation, so I won't go into it too much now, but it really helps that we've got all these health boards to come together to show what's best practice for them. We share our lessons learned and what best practice, and also what we've been struggling with, and if there's any help that somebody else has done a project that could help with the other health boards. And importantly, this group has enabled us to develop an All Wales working practice. So Andrea and Marilyn lead on all the policies that we've introduced. They've done the All Wales Thromboprophylaxis policy, which we're all doing the same now. They've touched already on the education package that they've done, which is going to be amazing, because we're all providing the education, but at least now we'll have an All Wales one on ESR that will standardise our education, which is going to be amazing. And it acts as a support group and like a buddy system, and me and Andrea has already spoken about how to work with the VTE Exemplar Leads on creating like a formal buddy system. So not only are we helping our own health boards in Wales, but we can also spread our experience to the rest of the UK as well. And also this group has helped develop the thromboprophylaxis rule, and actually helped us to make cases for the other health boards to applying get thromboprophylaxis nurses in there, which is ongoing. So it's made a lot of changes. Like Simon said, they've done it a long before I was here, and it's really helped me to progress in my career and help our health board achieve what we have done. So for our upcoming revalidation, I've been thinking a lot on actually what has this meant to have the exemplar status, and how do I feel about the revalidation. And I think really revalidation plays a really important part of your exemplar status, because it enables you to ensure that continuous improvement is still happening, and that you're always striving for best practice, and you're always sharing the lessons learned to be the best practice, which again we do in this All Wales group, which is really helpful for the feedback as well. Revalidation also keeps VTE prevention as a priority for managers, and this is really important as well, I think, because we've had quite a shake-up in our management the last couple of years in BCU, so we have a lot of new managers. So having the exemplar site status and coming up for revalidation really keeps it priority for those managers, and that is not forgotten just because you've got the exemplar status. And it also acknowledges the hard work of all our staff that's worked really hard to do the work and maintain our targets. And it is reassurance for our patients that that we've worked so hard to get this status, but actually we're working even harder to keep it as well. And so there I get reassurance that we are an active group in the health board that is trying to do the best to prevent them getting VTEs. Then along came 2020, to go back to our timeline, when COVID-19 pandemic hit us. So when the COVID-19 pandemic hit, the council and suspended our HAT service, so we all got moved into ICU and COVID wards. So that was suspended for a year or so. So when we came back, we've had a lot of work to do to catch up on previous RCAs and restart all the education and walkarounds. And what we found by collecting the data for 2020-21 is that from going from 0 preventable HATs, we've had several potential preventable HATs now, which was quite upsetting at the time, thinking, you know, we did so much hard work to get where we was, and it slipped down now because there's been nothing in place while we were suspended. But then, you know, as Batman says, we fall so that we can learn to pick ourselves up, and I think that is an important message for everybody, especially what everyone's gone through the last couple of years. Even if your practice does slip, there's always a way that we can start fresh and get new ideas. So because of this slip in our practice over COVID and BCU, we've come up with a new quality improvement programme. And so what we've done is that we've called it our Apple approach. So it's an MDT approach based on our walk around, but with a little bit extra added. We've reviewed all our lessons learned from our RCAs, and also from the Getting It Right First Time study that came out. So for our Apple, A stands for assessment, and this is to make sure the VTE risk assessment is completed in the Clarkin Performer as well as on the drug card, and that is correct, and that the prescription is correct. And then first P for peer review is for our consultants on the post-take round. They are now starting to review, make sure that the VTE risk assessment is completed and the prescription is correct and the VTE box is filled in correctly on the drug card. And then the second P is for pharmacy check. So we have a lot of pharmacy based on the ward, and they're really good in checking all the drug cards and the medication. But they've always checked to make sure, and like Andrea said, they did the safety thermometer, make sure that VTE box is completed and the prescription correct. But what they're also starting to do now for us is to look in the notes and make sure that the VTE risk assessment is done and is correct and correlates to the drug card. So that's been a massive help to start driving our compliance back up. And L is our leaflet to patients. So again, from Getting It Right First Time study and from our RCAs, We're very good at giving patients verbal information and explanation of thromboprophylaxis, but the written information was a bit hit and miss. Some departments would do it, some wouldn't. So we've now put in place, we've got the IDO leaflet, which is the Welsh VTE leaflet, because it's bilingual in Welsh and English, which we have to give. And then we've also got Thrombosis UK leaflet to give out. So we now make sure that every patient on admission will get a leaflet given to them, so they have the written information as well as verbal. And then the E is for education. So this is quite broad. It will be the education for the patients, which hopefully the written and verbal information will help in them understanding the importance of the thromboprophylaxis and signs and symptoms of VTE. And it's also the education for the staff. So we do a lot of education on our walk around. We do monthly educations where they can come and have education face to face. And we've also restarted our VTE study days that we do several times a year across the health board as well. So these pictures are just examples from our Apple approach. So we've got our drug card, and then on the top I've enlarged the sticker so you can see we've got little stickers saying VT leaflet given, and so when we give the leaflet we stick that on the drug card now. So we was going to put it in the notes, but then it would get missed and the patient would end up with like a pile of leaflets. So we've put it on the drug card so everybody's aware that that patient had written information given, and if it's not on there we'd be given it and then a sticker put on so nobody gets missed. And then on the other side is our checklist that we do for our post-take ward rounds. This is still like in progress, so this has changed several times already, and it may change again in the future, but this is what it is as it stands at the moment. So from this we've really learned a big lesson from our ups and downs really, and we've learned that maintaining exemplar site status involves staying committed to improving practice to prevent VTE. It's not that you're the best in the country and you have to stay the best. It's about always having that drive and enthusiasm to carry on even if you have incidences which are not best practice, but it's important that you learn from it and you share that learning and you carry on to get back to where you was. So sharing lessons learned and continue to display the qualities of an exemplar site is really important, and that really helps you if you're going through a period of things that's gone wrong or an incident that, you know, a missed VTE, or you've got a potentially preventable hat. So because of this, we've developed quite a few new improvement projects, such as the Apple. That safety checklist was done a few years ago where we added thromboprophylaxis on every part, and that really helped to reduce our surgical hats as well. So hopefully all these new improvements that we've been doing will help us to maintain our compliance again, and also to return to 0 potentially preventable hats. So really from our health board perspective, from having a full-time thromboprophylaxis nurse in place, it has a lot of benefits. It's enabled us to comply with the NICE guidelines and policies, and it's helped deliver the education to both staff and patients. It's helped us to perform and sustain our target levels, and it's helped compliance in completing our RCAs and spreading the lessons learned. And it's also been a specific nurse in place purely for VTE prevention is able to support our clinical leads, support all the staff and the hospital management teams, and also our patients as well. And it's really helped to change our workplace culture. And from 2017, when I first started, to now, you can tell there's a massive change in workplace culture. All the clinicians are on board, and it's a big difference from the struggles I had when I started to get people involved in VTE prevention to now, where we've had this lapse because of the suspension. But when I've gone back to them, they're all like, oh, we're glad that we're back. What can we do to help? What can we do? And they're all on board, and they're actually doing a lot themselves, rather than me trying to drive it purely by myself. So our figures have actually gone up a lot faster than they initially did when I first came into post, which is really reassuring. So hopefully by this you'll see that the improvement work done in BCU has shown that it is beneficial to have a dedicated thromboprophylaxis team, and that by achieving exemplar status it does shape practice. I think without the exemplar status it could have been very easy for us to come back and see how we'd slip to lose our motivation. But I think by having the status, making sure the managers are still on board because we're coming up to revalidation, has really helped us to go straight back out at it and not spend time moping around about how we've slipped, and actually seeing, okay, how do we improve on this? And that's actually made us do a lot more projects that we wasn't expecting or thinking of, and I think it's really helped all the staff to come back on board so quickly as well. And it is possible that we can have 0 potentially preventable hats in a year because we've achieved it before. So I think it's perfectly okay for us to say we can achieve it again, and that you can protect your patients from harm and you can achieve exemplar site status. Because if we've done it when we started off in not a good position, we did have a lot of help. Like I say, we had Andrea, Marion and Simon and the rest of the team in the All Wales group, which was really helpful for us. But now the exemplar status have the buddy system, which you can link up with hospitals that have got status. So I think it is for anybody wanting to do it and thinking to do it, that you can achieve it. It's a lot of hard work, but it's worth it in the end, especially for your patients. And that is it. Thank you for listening. That's my email if anybody wants to contact me, and if you want to contact the VTE Exemplar, that's the email for them if you want any information regarding achieving the exemplar site status. Any questions?
Christine. Absolutely perfect. I think you've demonstrated there how far enthusiasm goes. And one of the questions that have come through is, how did you achieve no hats? And well, lots of the health boards in Wales have achieved no hats because of the hard work that has gone on over a lot of years. And I think what I can sort of confirm with what you're saying, it's when somebody in the orthopaedic team, one of the consultants, stops you in the corridor and says, can you tell me what our hat rate is? And is everything going okay? And they're actually interested. And it makes such a huge difference. Yeah,
it does. And it ends up like a snowball effect as well. And I think from my experience, because I came from England, from a very busy acute teaching hospital, which you've already explained the difference between sequins and Wales, and I thought, how can you be so low in compliance when I was talking to my clinical lead? But I think what I've learned over my journey is actually, although England was leading as in the compliance because they've had the sequin help, we've actually led it through education, and by doing it through the education, it's actually sustaining better because they understand why they have to do it. So I think that is a big play in it. And I think a lot of clinicians, when you say, oh, we're thromboprophylaxis, VTE prevention, they're like, oh, what do you want? It's quite boring. But the more they learn about it, the more involved they come, the more interested they are. They think, oh, this is really interesting. We didn't realize how interesting this is. And they get on board, and people now come to me with, can we do this quality improvement on thromboprophylaxis? Is where before I was like, come on, surely you want to come and work with me. And it's like turned now because they're getting interested in it.
Yeah, it's made, it's true. And it's another comment that came through, which you'll be really pleased about, and I know I am because I'm revalidating as well in September, is that, oh, hold on a second, my battery's running low. The criteria changed in February 2022, and it's now shorter. Yay! So hopefully it won't take me 3 months to do it. I'll be able to do it in 6 weeks. So I'll have a look at that after this this meeting. And yes, the buddy system that you were talking about, when we meet up again with the All Wales group, we can look at supporting colleagues and get hopefully all of the sites in all of the 7 health boards and Valindra to achieve the status. That would be
Yeah,
brilliant.
because I think, as you said, they've all come a long way over the last few years, and it's from the work that you, Marilyn, and Simon started off all those years ago, and I think it's really picked up, hasn't it, the last 5 years?
Well, there was I think originally five people, and really out of the people who started it, I think Rachel Raymond, she still dips in and out. Sarah Lewis in and Iron Bevan, she occasionally dips in and out. There was another haematologist from the Royal Glamorgan who I can't remember his name, but yeah, it's great because it shows that with perseverance and determination, it can be done. And I'm not saying it's easy, because it's not, because it's taken like 20 years to get to this point. Another question, which you might be able to, you might want to answer this one, Marilyn. Do you include missed doses? Yes, we do.
Yes, we do.
Yes, we do.
Short answer is yes, we do include a missed dose. And how do we tackle missed doses? Well, we would be sort of interrogating the notes and then discussing that at the clinical board level, and hopefully they would then discuss it with the individual or the ward in retrospect of what happened, just to look at how to improve practice, really, what the reasons were and how we can address them.
But one of the reasons, and it's not an excuse, it was identified that if we have bank or agency staff, there tends to be missed doses. So one of the ward managers, because if we have missed doses, I usually engage with the ward manager and go and have a chat with them, and we have a look and see if the nurse was a regular nurse or if it was an agency nurse or a bank nurse. And one of the ward managers, what she had started to do, and I'm sure this happens in other places, it certainly does in places like intensive care, is to when they have the handover, for the nurse to hand over the bay, and to go to each patient and check that everything has been completed on that patient for that 12-hour shift, so that if there are any medication that's not been signed for, because it's not only thromboprophylaxis that gets missed, it could be other medication, and that everything is tied up at the time that they change over to the next shift. I know that's quite time consuming, but it does offer a really good handover, and you know that everything you've handed over is complete. So that's one possibility. And what was the other thing? Oh, the last question, and either Christine or Marilyn or myself can answer this. And in fact, I think Christine has answered this. Who gives verbal and written information to patients? Well, everybody really. Pharmacists, nurses, a clinician.
Yeah, I think that's the whole point of having the MDT approach, is that if it gets missed at one stage, it'll be picked up by another clinician in the next stage. So, I mean, generally in our ward, the nurses or maybe the housekeeper will give them the written information, and then the nurses are there to give verbal and explanation if they've got any questions when they're doing the thromboprophylaxis round with the drugs on the night time. So I think it doesn't really matter who gives the written information as long as they've got it, because they can read it and then ask the nurse when they're giving them the thromboprophylaxis at 6 o'clock. If they've got questions, they can ask the nurse, and she will be then able to tell them the answers. So I don't think it matters. I think what's important is that they're getting it, so they're aware. Some people aren't bothered, they just put it in the bin, and that's fine, as long as we tell them the importance as well, and we can do as much as we can. But it is important because, like you're saying, for the missed doses, that in Wales we class 1 missed dose as potentially preventable. So that is where some of our preventable hats do come from. So we've done a lot of work with the nurses and charge nurses on the wards, haven't we, to try and say the importance of that and make sure that everything's documented. If there's a reason for not giving it, state that reason, don't just leave it blank.
That leads into another question that's on there. What if patients refuse doses? So you can't force a patient to to take the thromboprophylaxis dose, but if you explore with the patient what their concern is, make sure they understand the reasoning for it, and they still refuse, then it comes down to documentation.
Yeah, and documenting that is really important, because quite often you see a drug hasn't been given and it's not been documented at the end of on the page at the back of the medication chart in Wales why it wasn't given. And as we all know, if it's not documented, it didn't happen. And the same as if a patient's got a bleed, or if they're waiting for a scan, if they're a query CVA, if there's any contraindication at all and they are not to have thromboprophylaxis, it's as important to document why you're not giving thromboprophylaxis as documenting why you are giving thromboprophylaxis. So just to remind people of that. I like your sticker as well.
Oh, thanks. Yeah. I was just going to say, on our chart, in our medication chart, we've got a contraindication box in our VTE box, which is really helpful as well.
Yeah.
But regarding refusal, I tell our staff that even if the patient's refusing it every day, do not cross it off and mark every day that they refused it, because we've had an incident previously where it's been crossed off and then they said, well, I would have had it. Well, you refused it for a week and a half. So it is important that we carry on every day asking them, because they may change their mind.
Yeah, absolutely. Yeah, so thank you again, Christine.
You're welcome.
I think we've answered all of the questions.
So there's a couple more.
Oh, is there?
Yeah. So one is, have you not had any cases where medication or patient were not available for the dose administration? So I guess if they'd gone to, if the patient gone to X-ray or CT or somewhere else.
Yeah, that has happened. We've had patients who have come from other hospitals. We have like a rehabilitation hospital or centre, and patient was sent from there because they'd had a fall in the late afternoon, and they came down. And because they'd had a fall and sat in A&E then till about 4 or 5 o'clock in the morning before they went back to the centre, then yes, it was missed. And if it was missed because of that, it would be classed as a potentially preventable HAT, because although the patient's been moved from one centre to another, we must ensure that A&E, and particularly with all of the patients who are sitting in ambulances at the moment, maybe for up to 24 hours while they're waiting to get into either the main A&E department or into the ward, we must make sure that these patients are still risk assessed. And I think risk assessed and treated, and I think that's one of the things which bringing back in, certainly in Wales, this now drive to make sure that the full risk assessment is done, and having the standards and linking in with Welsh Risk Pool, that hopefully we'll be able to address areas such as, A&E, when people come in from other areas, and while they're in that department, they're not given their thromboprophylaxis treatment. Patients, there have been patients who have gone home. That's quite often people who go home for a weekend and don't have their thromboprophylaxis over the weekend. That's an interesting one. I guess if somebody's...
You could argue if they're going home for the weekend and they're mobile.
Yeah, they don't need it.
Then could you reassess whether they needed it, I suppose. The other part of that question was, did you, what if the medication wasn't available? The closest thing to that we've had is where there was a shortage of Clexane, which is the one we use, and then they came up with a sort of bio-alternative one that we used for a while. But generally speaking, it's known in advance and addressed. So
and it shouldn't be a shortage in the hospital, because it's a critical medicine anticoagulant. So there should be a supply somewhere. If you've run out on your ward, you should be able to borrow it from another ward.
The pharmacists know in advance normally that there's going to be a short. There's one more question before we have to finish.
Yes.
Do you audit if patient information was given, and do you document if patient information is given?
We document it when it's given in pre-assessment, and we document it in the. It goes on to the the admission documentation, which is electronic, and there's a section on there saying thromboprophylaxis information given to patient. And there's also a section has the patient asked for post-operative information, and that's also yes if it's given, yes if the patient specifically asked for it. And also we have an anti-embolism stocking form which has to be completed by the clinician when the patient's admitted, to check that the patient has no contraindications. That's on one side, and it's documented on there at different points when the patient's legs measured, are they given the information out of the packet. Interestingly, a lot of people didn't realise that the packet contains the guidance when the patient gets discharged home and how to care for the stockings and how to care for the leg. So we give that, and that's documented. It's also documented when the nurse returns to check the patient's stockings are fitted correctly, and they give the patient information then. And when the patient's discharged, they also give the patient information about when they should take the stockings off and washing and that type of thing. And we've also moved to, instead of having anti-embolism stockings on the medication chart with a little circle with an arrow on it to sort of suggest give it, we actually put it in 4 times a day. So every time the nurses do the medication round, they check the stockings and sign to say they've checked them. And that's been really, really useful, because we've actually got a record that they've been checked every time we've done a medication round. And so we're trying to sort of move in that direction. And we're also looking at patients not going home with anti-embolism stockings unless they're absolutely warranted, because the amount of people who leave hospital with a pair of anti-embolism stockings on, who are fully mobile, and ring you 2 months later and say, should I have taken these off? That in itself is, you know, that's something hopefully of the past, and we need to move away from that.
Okay,
orthopedics.
we've got no more questions now.
That's all of them, is it?
Yeah, all done.
Okay, right, so we're going to close it there. Thank you so much for everybody for joining us for this session. Sorry it's gone over a little bit, but they were really good questions, and I think they were, you know, we wanted to answer them to, you know, respond to those people who put the questions, and hopefully all the other attendees were interested in our responses. So thank you again to Christine, to Professor Simon Noble, to Marilyn, and to Joe for organising this session today. And hopefully we've given you an idea of where we are in Wales and where we're planning to go. So thank you very much, and goodbye everybody.